So my presentation is dedicated to frontline therapy in the elderly. So these are my disclosure. And as said by Dr. Palumbo, myeloma is definitely a disease of elderly patients. So this is the epidemiology program in the US, one of the most recent issue. And as you can see, the median age was 69. Approximately 1/3 of patients had an age over 75, and approximately 10% of patients had an age over 85. So this is definitely a disease of elderly people. And looking at standards of care for elderly, we established together some years ago two regimens. So one of them was the combination of melphalan, prednisone, and thalidomide. So this is an IFM study which led to the approval of MPT in, at that time, the 27 countries of Europe in 2008. And then because we did a lot of MPT studies especially in Europe, we did a meta-analysis which was published in 2011 based on 1,700 patients, showing again that we got a PFS benefit and a survival benefit with the thalidomide. But speaking on thalidomide with Bart Barlogi in the room, I have to say that you rediscovered thalidomide, in fact, and so this is due to your wonderful presentation some years ago for thalidomide in relapsed refractory myeloma patients. So we were just followers, in fact. So we did some good work, but we were followers. Then almost at the same time, the VMP regimen was established based on the very well-known VISTA studies. And as we all know, the Bortezomib has evolved over time, moving from twice weekly to weeklies and moving to IV to sub-Q. And very briefly, these are the final results of the VISTA study. So the final analysis was published in 2013. And as you can see, a nice TTP benefit, median TTP being 2 years for the VMP regimen. And this TTP benefit translated into a survival benefit with median survival 56 months for the VMP patients, which is almost 5 years, in fact. And so this is definitely a good regimen for elderly patients. So as we know also, some other Bortezomib-based regimens have emerge, such as the combination of Bortezomib with cyclophosphamide. The combination of cyclophosphamide and thalidomide has also been done, especially in the UK. Then after these two regimens, we got a new one recently, and this was based on this study, which was, as you know, initially designed by the IFM. And because we had an experience with melphalan, prednisone, and thalidomide, we considered this MPT regimen as a control arm based on two studies we did, one in patients 65 to 75 and another one in patients over 75. And we decided to compare this regimen with two different lenalidomide low-dose dexamethasone regimens. So one given for 18 cycles and the other one given continuously. And so very briefly, this is the PFS at the time of the last update, which was March 2013. As you know, we enrolled in this particular study a huge number of patients. So we enrolled approximately 1,600 patients. And the median PFS was 26 months for the continuous lenalidomide dexamethasone arm versus approximately 21 months for the two other arms. And this is the survival at the same data cutoff, showing median survival approximately 5 years for continuous Lendex versus approximately 4 years for MP in combination with thalidomide. The patients who received Lendex for 18 cycles had a quite good survival as well, which was not that different as compared with the survival we had for the continuous lenalidomide and dexamethasone arm. So this led to a discussion which is very common. So the discussion whether we should give lenalidomide for fixed duration or we should move to with continuous lenalidomide and dexamethasone. So the good news is that we will have the final analysis of this study very soon. The final analysis will be done in the next couple of months, and will be ready for the next ASH meeting. Because we had approximately 1,600 patients, so that the study was a great opportunity to do a lot of sub-analysis. So we investigated quality of life, and we investigate patients with severe renal insufficiency, and we also looked at very elderly. In this study, 35% of patients had an age over 75. And so we have a subgroup of 567 patients with an age between 75 and 92. And so we decided to perform this comparison between patients 65 to 75 and patients over 75. So this is the PFS. As you can see, this significant difference in favor of the continuous arm in patients 65 to 75. And these curves are quite interesting as well. So because if you look at median times, in fact, there is no difference. And but if you look at long term, so if you look, this is the 4-year PFS shown here, there is a difference in favor of the continuous arm 4-year PFS, moving from approximately 10% to 26%. So this, and this is, what is true for PFS is also true in a certain extent for survival. And so these are the survival curves for the patients 65 to 75, and the curves for patients over the age of 75. And as you can see, this is the survival for continuous Lendex, which is 52 months, versus approximately 38 months for patients receiving melphalan, prednisone, and thalidomide. And in the same way, the Lendex 18 curve run parallel in between the two other curves. As I said before, and we had a very nice presentation on renal impairment this morning by Dr. Lung from Mayo Clinic, and he mentioned the use of Bortezomib, which is a good drug for patients with myeloma and renal insufficiency. In the first study, we enrolled patients with creatinine clearance less than 30, which is not common for registration studies. And in fact, we have a subgroup of 147 patients representing 9% of study population with creatinine clearance less than 30. So we have very elderly, very sick patients, and some patients with very severe renal impairment. So in this particular study, for example, we accepted patients who were 85-year-old with creatinine clearance 10. And that means that the population was somewhat close to, not a real-life population, but somewhat close to a real-life population. And so this is the PFS for patients with no renal insufficiency, mild renal insufficiency. So this is creatinine clearance 50 to 80, 30 to 50, and less than 30. And as you can see, in all these situations, in fact, there was a benefit in favor of the continuous arm, even so this difference was less pronounced in patients with very severe renal impairment. Because of the, I have no time to discuss all sub-analysis. The last sub-analysis I would like to show you, and this is also in line with the very nice work done in the past few years by Dr. Palumbo and colleagues in Italy, is the frailty assessment. Antonio Palumbo established and published in 2015 this IMWG frailty score based on age. These two scores, LDL and ILDL, and the Charlson Comorbidity Index. And so in the first study, we did not have the LDL and ILDL. So we did a proxy which was based on a quality of life questionnaire, so called EQ5D, which is a very common quality of life questionnaire in registration studies. And so in the same way, we were able to define fit, intermediate, and frail patients. So we designed this new score, I would say, based on in this particular study. And this is what we got for PFS on the left-hand side and survival on the right-hand side. And this is basically the score in combination with ISS. So we will present soon other results with the revised ISS. So this is the traditional ISS. But as you can expect, these are the fit ISS1, and basically these are the frail ISS3. And the same is true for the survival. So these are the frail ISS3 and the fit ISS1. So the score is effective, in fact. So it seems to be quite good. And if you look at the PFS in different treatment arms, so this is the PFS by severity group for all treatment arms, for the fit, intermediate, and the frail. And this is the benefit of continuous Landex versus MPT for the fit, the intermediate, and the frail patients. And the same is true for the survival. So this is again the survival by severity group for all treatment arms, and this is the benefit of lenalidomide versus thalidomide in the fit, the intermediate, and the frail patients. So I'm not saying this is the best score, or I am totally convinced that new scores will emerge, and I do believe that there is some interest in frailty scores in myeloma. For us in the IFM, this score is probably a way to define elderly transplant-eligible patients, in fact. So this is what we would like to do in the next, one of the next IFM study, is to define in a logical way elderly patients who will be transplant-eligible. So we may move to transplant in some patients between 65 and 75 based on this, and that will be helpful for us. The only issue I have with this is that if you want to use this score as a way to define or to help define transplant eligibility, the frail, it's good to have two groups. Basically the frail and the non-frail, or the fit and the non-fit. But if you have an intermediate group, that's not very convenient, because you do not know exactly what to do with patients with intermediate fitness. But it's basically work in progress. So briefly, this is what we have done together in the past 10 years. This is the traditional MP, so we established that melphalan, prednisone, and thalidomide, melphalan, prednisone, and bortezomib, and some other bortezomib-based regimens are better regimens as compared to MP. This was true also for MP in combination with lenalidomide and lenalidomide maintenance. This is what has been done in the context of the first study. As you know, there is no head-to-head comparison between VMP and lenalidomide and dexamethasone. And then this is what is ongoing. At least these are not all, but these are some of the most important ongoing studies combining either lenalidomide and dexamethasone or VMP or MP with new agents. So the majority of these studies, in fact, are based on lenalidomide and dexamethasone, but not all of them. This is a VMP versus VMP daratumumab study. This one, which is ongoing and which will be presented at ASH at the end of this year, is a VMP versus KMP study, and these are the combination of lenalidomide, dexamethasone, and ixazomib, bortezomib, elotuzumab, and daratumumab. So these studies have been completed for enrollment or are currently enrolling patients. And finally, you have, I would like to mention this Spanish work presented and published by Dr. Mateos. So combining one way to combine lenalidomide and bortezomib is just to do VRD, basically. Another way is to combine the VMP and lenalidomide and dexamethasone. That could be a sequential approach, or that could be an alternating approach, and this has been done by Spanish colleagues. Very briefly, some words on the VRD. We heard at ASH at the end of last year that on this SWOG study, which is a large phase 3 study, lenalidomide. This is continuous lenalidomide and dexamethasone. This is VRD followed by lenalidomide and dexamethasone, so 8 cycles of VRD, then lenalidomide and dexamethasone. And this is the PFS on the left-hand side and the survival on the right-hand side. And so the study was not specifically designed to look at elderly. So in this particular study, you have some young patients. But if you look at the PFS, so the median PFS was 30 months for lenalidomide and dexamethasone versus 43 for VRD. And this translated into this survival benefit, so median survival moving from 64 months to 75. This is also in line in a certain extent with the first study. So in the first study we had median survival approximately 60 months. Here we have some young patients and median survival is 64, but the VRD regimen did significantly better. One issue with the VRD for some elderly, very elderly and frail patients is that this regimen could not be tolerable. And some colleagues in the US have developed a new VRD regimen. So this is VRD lite from Dana-Farber. I should ask Paul Richardson to send me a better slide, honestly, or at least more slides. But this is at least, this is the regimen. And this is a regimen using a lower dose of lenalidomide, and this is weekly bortezomib. So this is just a way to say that the VRD can be adapted to elderly and frail patients in a certain extent, and this led to at least VGPR in more than 50% of patients after 4 cycles, so the regimen seems to be effective as well. Finally, looking at I mentioned some ongoing studies, and these are 3 of these major studies using lenalidomide and dexamethasone as a control arm. So this is the elotuzumab study, which is called ELOQUENT-1. So this is totally continuous. So this is continuous lenalidomide dexamethasone versus continuous elotuzumab lenalidomide and dex. This is the XIIIth study, which is called TOURMALINE-2. This is a little bit different. So dexamethasone is discontinued after 18 months, and then patients receive a lower dose of ixazomib and a lower dose of lenalidomide. And this is the daratumumab study. This is continuous lendex, and this is daratumumab lendex. With one important difference is that at 2 years, the lenalidomide and dexamethasone is discontinued, and then patients receive daratumumab given as a single agent. So looking at these studies they look the same, but in fact they have some differences which may be important at the time of looking at study results. So we do not have, by definition, we do not have study results in the frontline setting, but we got recently some results in the relapse refractory setting. So these are 3 lenalidomide dexamethasone-based studies. So this is ASPIRE. This is the ELOQUENT-2 study, so ELO lenalidomide and dex in relapse refractory patients. And this is the TOURMALINE study in relapse refractory patients. So we got a benefit in terms of PFS in these 3 major studies in favor of the triplet regimens. And so we might expect to see the same in a certain extent in the frontline setting as well. The last study I would like to mention, because we do not have so far phase 3 results for daratumumab in combination with lenalidomide, but we have a small phase 2 study. So this is the phase 2 part of the lendex daratumumab study in relapse myeloma patients. So this is based only on 32 patients, but as you can see, approximately 80% of patients achieved at least a partial response, and we had 2/3 of patients achieved at least a VGPR, and 1/3 of patients achieved a complete response. So these results look quite impressive, and this might be even better in the frontline setting as well. So this is the landscape, and you can find in blue clinical studies and with bortezomib, ixazomib, carfilzomib, elotuzumab, and daratumumab. And these are the expected dates for potential approval. And so between 2018 and 2020, we may have, for elderly transplant-ineligible patients, many new regimens. So Ixazomib in combination with lenalidomide and Dex, Carfilzomib in combination with MP, the Elotuzumab regimen, and potentially 2 different regimens with daratumumab, the VMP Dara, and the lenalidomide dexamethasone and daratumumab. And finally, I would like to show you a way to illustrate the progress we did in elderly patients. So this study is the last study we published in the IFM for elderly patients before the availability of thalidomide. So the study was called IFM 9501. In fact, the study was published 10 years ago. And so as you can see, the median survival was approximately 3 years. And this is the benefit we noted in the context of the first study, moving from median survival approximately 3 years to median survival approximately 5 years with continuous lenalidomide and dexamethasone. And we may expect additional progress with triplet regimens based or not based on lenalidomide and dexamethasone, but we may move median survival in the elderly from 5 years to 6 years in the next few years. The last one is the IFM one. So thank you very much for your attention.